All right. Why don't we go ahead and get started? It's my honor to introduce a good friend and a brilliant thinker, Dr. Scott Rivkees. He's a professor of practice at the Brown University School of Public Health. He's previously the Surgeon General of Florida and saw us through the worst part of the pandemic, which I can guarantee you is a long way from being over. He's going to tell us how we need to structure public health and medicine to best address the future emergence and examine some missteps in the past and present. Dr. Rivkees, go to it.
Thank you. Your call has been forwarded to an auto.
Thanks, John. Can you hear me okay?
44334 is not available.
All right, somebody's getting a voicemail. Well, listen, it's such an honor for me to speak with everybody. With the view I have on my screen now, I only see the presentation in front of me. I don't see names and faces, but when we go to questions, I'll close my screen to be able to do that. So again, really thanks so much. And I see that we have some special guests joining today, Dr. Uli Cho, one of our county health officers who just did a phenomenal job. Uli, I miss working with you. And I see also Jose Montero from CDC. CDC has really just done a brilliant job during this pandemic response. And Jose, thanks for all your help. So today I'm going to talk about some ways I've thought about this a little bit differently, how we're responding to COVID-19 then, now, and in the future. Now, this is what Rhode Island looked like last Friday when I was putting together my talk. This is the first time I've had a snow day in a long time, and this is a view of Narragansett Bay, which is about a block from my house. It's beautiful, but it's also a bit chilly. So where are we in terms of this really brutal worldwide pandemic? So right now, there have been nearly 500 million documented cases of COVID-19, with nearly 6 million deaths. In the United States, we've had 80 million documented cases and nearly 1 million deaths. And in Florida, we're under 6 million cases and nearly 70,000 deaths. However, the true toll of the pandemic is probably greater than that. Shown here is a table from a publication in Nature a little while ago, actually looking at what the estimated deaths are for COVID-19. And it's somewhere between 12 and 22 million individuals who are thought to have succumbed to this very pernicious virus. How does this compare to other pandemics? The most recent 100-year pandemic was the H1N1 influenza around World War I. There, it claimed about 75 million people worldwide. And one of the notable differences between the 1918 pandemic and the current one is the population that it's affecting. That earlier pandemic really affected young adults, with the average age being somebody in their 20s, compared to now where individuals who are older are especially vulnerable. So there's lots of talk now about shifting from a pandemic to an endemic situation. So in terms of endemic disease, and yet this refers to a situation where there is general low spread throughout the population. But I think right now, because we continue to have areas of large spread, that we still are in a pandemic situation. As we are seeing worldwide and also in the United States, we are seeing changes in terms of restrictions being lifted. Denmark was among one of the first European countries to lift all of its COVID restrictions. About 2 weeks ago, the UK restrictions were lifted. And California state, which really had very rigorous mitigation measures, was among the first states to actually spell out what the playbook is going to be moving to the next phase. So the question we all have to ask ourselves, and we all hope that the answer to this is yes, is the COVID-19 pandemic over with Omicron? I think we have to be honest and say we really don't know. In the middle inset, you actually see a phylogenetic tree of COVID-19, showing the different offshoots of the different variants, the Delta variant, Alpha, Gamma, and more recently, the Omicron variant. And as we're aware, we're now seeing changes even within this Omicron variant with this BA2 lineage appearing. And at the end of last week, the World Health Organization is now reporting that more than 35% of the new cases of COVID-19 that they're aware of are actually of this BA2 variant. The clinical characteristics still are being defined. Why does this virus mutate so much, and what are our challenges ahead? So we're dealing with a positive stranded RNA virus that's almost 30,000 bases. RNA viruses mutate more than DNA viruses. And if we look at the 3' end, this is where 4 important proteins are encoded: the spike protein, envelope protein, membrane protein, and the nucleocapsid protein. Why is this called SARS-CoV-2? Because it's very closely related to the severe acute respiratory syndrome pandemic virus of more than 15 years ago. So that's why it's called 2. MERS, Middle Eastern respiratory virus, also is very closely related. So in terms of mutations that we've been talking about really have been of the spike protein. And the cartoon shows differences in the spike protein mutations of some of the different variants. We have the UK variant called the Alpha variant, which different changes: beta, gamma, Delta. And then with the Omicron variant, a tremendous number of mutations. And when these mutations change, the ones that tend to have more contagiousness generally tend to overtake the earlier ones. And these mutations really affect the ability of this virus to bind with greater affinity to the receptor, which is the angiotensin converting receptor, which is the target. It's also interesting in terms of where are these different variants occurring from, and something that we really need to learn about. With the Omicron variant, there was a paper published out of South Africa where they thought they traced it back to an individual who had uncontrolled HIV, who had a prolonged infection. The Alpha variant or UK variant, there was also a report in the UK where they thought they were able to trace it back to an individual who also was immunocompromised that had lingering infection as well. One of the other things I think that we need to pay attention to is, even though we talk about spike protein mutations, are mutations of the RNA-dependent RNA polymerases, which can play a role in terms of replication of this virus. And shown here is a screenshot from the abstract for a fascinating article by Jennifer Doudna's group at UCSF, showing that one of the reasons Delta was so virulent is that it had much more replication properties within cells and often 50-fold greater viral loads. So this probably is related to the fact that this virus variant probably had greater RNA polymerase activity. So, thinking about going forward, we really have to, we're transitioning, we've been with this for 2 years and really have learned a lot, experience we can build upon. We need to allow society to continue to function as close to normal as possible. We need to minimize morbidity and mortality. And a lot of this really has to do with making sure that we continue to protect those who are most vulnerable. We need to ensure that we have adequate healthcare capacity. And my thoughts are with everybody who has played a role in this incredible response. Mitigation strategies need to be evidence-based. How do we achieve population immunity? And how do we provide realistic expectations and build public trust in this response? The reality is this, though, is that we are not going to eradicate COVID-19. In fact, the common coronaviruses which are out there now that affect largely children are thought to be a derivative of the 1890, it was called the Russian flu, which was pretty clear that was a coronavirus. The H1N1 flus that we're seeing now is a derivative of the 1918 Great Pandemic. We need to recognize that mitigation measures reduce, but they don't eliminate the risk of COVID-19. And similar to other vaccines, these vaccines will protect against severe illness, but don't completely protect against infection. The other thing which I like, writings of fellow pediatrician Aaron Carroll at Indiana University, is that safety is not binary. We have to stop saying things are safe or unsafe. Rather, there's a balance. Also, as we've seen, the response to recommendations is going to be variable, and there can be both polarized and passionate viewpoints. And that to end the pandemic, we really need to center the population in our thinking. So this is an electron micrograph that came from NIH laboratories of the SARS-CoV-2 virus, called the coronavirus, again, because you have the spike proteins on the outside, which make it look like the corona of the sun. Some really interesting articles came out over the weekend talking about the potential origins of this, and both these articles suggested that these came from the Wuhan Center, initially with bat, with another animal intermediate host, which then jumped into humans, and then based upon epigenetic footprinting and timing that, again, points to the Hunan seafood market in Wuhan as well. But again, this is something that really is important to discern, and as it plays an important role in terms of guiding prevention in the future. I remember relatively new into my role right after 2020 set in, getting an email alert from CDC, which basically had the text shown here, where they said that on January 3rd, a total of 44 individuals with pneumonia of unknown etiology were reported in China. I remember saying that's really unusual to get this kind of notification. Then a week later, within a week, the virus had been sequenced. It was known to be a novel coronavirus. In the United States, we had our first case in January 21st of 2020. This was a gentleman who returned from Wuhan, China, to the state of Washington. And then the spread in the United States really happened really quite rapidly. So January 21st was when the first case was. The middle screenshot shows March 25th, and at this time, and probably a lot of the spread was in the Northeast and appeared to be coming from Northern Europe to New York City. I should point out in the middle, you see Nebraska, where there's a cluster of cases there. And these were the individuals who were on the cruise ship, the Diamond Princess, who had been evacuated and were at a quarantine center. And then within a month, the virus had really spread throughout the country. Early on, with tremendous activities of our contact tracing teams, we were able to actually trace many of the initial cases. We found the early cases in Florida came from individuals from New York, individuals from Italy, Ireland, and also Egypt, as there were a number of individuals who returned on cruises from the Nile, where they were exposed and infected at that time. Vice President Pence was named in charge of a coronavirus task force, and one of his first trips, official events, was actually coming down to Florida, and there was a meeting at West Palm Beach Airport, and here is Vice President Pence with Governor DeSantis, Lieutenant Governor Nunes, U.S. Surgeon General Jerome Adams, and Dr. Red. We had our first case almost to the day 2 years ago. Before, we were sending our laboratory tests to the CDC to be tested. We'd had the COVID-19 kits provided by CDC, but they weren't approved for use. And then on February 29th, they gave us enhanced protocols to be able to, or revised protocols to be able to do testing. And the first day we did testing, we found two individuals. The first was a young woman who had returned from Italy. And the second was a 63-year-old gentleman from Manatee County who had not traveled internationally, but likely traveled to another part of Florida where he was exposed. Shown here is one of the early press conferences with myself, the governor, Lieutenant Governor Nunes, and also to my right is Deputy Secretary of Health, Dr. Shamara Robertson, who just did an absolute phenomenal job during this response. We ran the response out of the Emergency Operations Center. Those of you in Florida know that Florida does a brilliant job in terms of responding to natural disasters. And the Emergency Operations Center is in Tallahassee, and we have individuals from many agencies together, which really allows us to work and have a coordinated response. This involved Department of Health, Division of Emergency Management. I want to acknowledge the leadership of Director Jared Moskowitz, ACA, Agency for Healthcare Administration, where Mary Mayhew, who's now president of the Florida Hospital Association, was secretary then, followed by Siobhan Harris, and now Secretary Marsteller. And one of the things that we really should really appreciate and be thankful for is that we have a very integrated county system of departments of health and emergency management. So we have 67 counties, each have great county health department directors like Dr. Cho, and this coordinated response really allows us to push out messaging, mitigation strategies, coordinate different efforts. And not all states have this coordinated response, and it really speaks to the benefit of Florida having this situation in place. About this time 2 years ago, this is when the White House team, and shown here is Dr. Burse, introducing 15 days to slow the spread. We saw what was happening in parts of Europe. In Italy, hospitals just being absolutely overrun. We didn't know where things were going. How do we make sure that we preserve a hospital capacity? And then with these federally guided mitigation measures, they started talking about phased reopenings, and in the Trump administration engaged the states to come up with their own plans for recovery. And the plan in Florida, spearheaded by Governor DeSantis, was the Safe Smart step-by-step reopening program. And also, when we started having these periods that were referred to as lockdowns, we began to understand the social and economic impact of them. The plan that I put in place for the Department of Health, which really guided my thinking through the response along with other members of the agency, was called the STEPS plan. And what were the steps? Social mitigation measures or non-pharmaceutical interventions, contact tracing and testing, elderly vulnerable population protection, preparing and supporting hospitals, and stopping the introduction of COVID-19 into the state and facilities. In terms of mitigation strategies, we stood up websites, had social media campaigns, mass distribution. We pushed out millions of masks over the course of this pandemic. We supported schools, K through 12, colleges and universities. And I think we should all be very proud that for the 2021 school year session, that Florida schools were open, whereas in many other parts of the country, the schools were closed. We kept our colleges and universities open, and they did a great job. We had a youth campaign. We had a health equity focus. Worked closely with the Chamber of Commerce so the business community could understand what are the things that they could put in place to actually help their business continue to prosper. We worked with faith-based organizations. I issued public health advisories. Shown here is a screenshot from the One Florida, One Goal program that we had in place, protecting the vulnerable, hand hygiene, social distancing, wearing a mask. And then for public health advisories, again, avoiding crowds, protect the vulnerable as well. In terms of initial testing, this virus was sequenced in early January of 2020, and a few weeks later, the WHO came out with some testing strategies, testing kits. CDC, FDA developed their own kit, which were shipped to the state laboratories, and then this was modified and approved for use at the end of February. In terms of testing, we remember the days of people lining up to get tested at our mass state testing sites. We purchased when the first kits became available, had emergency use authorization. We purchased 600,000 of these kits. which we then distributed to hospitals throughout the state, more than any other state did at the time. We engaged universities. And then also, if you think back to these early times, we had trouble getting reagents, TACMI pipettes, other basic reagents for this. So we actually created a clearinghouse where we engaged universities to try to help research laboratories to try to help identify where the supplies were, which we could distribute. We established high throughput testing centers, expanded contact tracing, and right now I'm working at a school of public health, and we had engaged the schools of public health in Florida to have students, faculty members participate in contact tracing, which was something that Dr. Robertson really helped orchestrate. In terms of vulnerable protection, Florida is a very medically vulnerable state. So if you look at the population of the state, 20% of individuals in Florida are 65 years of age and older. That is number 2 per capita, with Maine being first. We had 170,000 residents living in nursing homes and assisted living facilities. So in terms of elderly and vulnerable protection, we realized very much early on that this had to be a major area of focus, as age-related mortality was apparent very early on. We were aware of the outbreak in state of Washington nursing homes, and then also what had happened in New York, where some patients with COVID-19 went back to the nursing homes and long-term care facilities. Now, at this time, part of the strategy of New York was they weren't sure what was going to happen with the hospitals and how did they preserve hospital beds. And right around this time when this was happening, my son, who lived in Jersey City, sent me this photograph that he took of U.S. hospital ship Mercy sailing up the Hudson River on a very gray and dreary day. I mean, this is what was happening back then. I remember, when I showed this photograph to other members in the Emergency Operations Center, I mean, the people were so stressed at that time. We didn't know which things were going, that people just burst into tears. I mean, it's a chilling image that stays with me. So in terms of elderly and vulnerable protection, we issued long-term care facility visitor restrictions early on. We had strike teams, 24-hour hotlines, as far as recommending that workers in nursing homes and assisted living facilities wear masks. I believe we were the first state to suggest that. We had surveillance testing, again, one of the first states, and really appreciate the cooperation with the Agency for Healthcare Administration, led at that time by Secretary Mayhew. Set up COVID-only facilities. So if a patient had COVID and was hospitalized, they would go to these facilities and decrease the risk of spreading to others. And then the Senior First vaccination campaign. Now, all this in terms of where looking at the outcome with this. So if we look before the Delta wave at the end of May this past year, at that time, there were more than 2 million cases in the state, about 36,000 deaths. And how do we compare it to other states? We were 18th per capita in terms of number of cases. And again, with one of the most second most medically vulnerable populations of the country, we are 27th in individuals who succumb to the virus. We supported hospitals with different treatment approaches. Again, 2 years ago, we did not have the armamentarium we have now. Remdesivir, dexamethasone, COVID convalescent plasma, monoclonal antibodies, new techniques which came out, which is important to look at, were these effective? And shown here are screenshots of showing their efficacy in New England Journal articles. In terms of remdesivir, the federal program began May 2020 and was shown to reduce illness. So the state played a role in making sure that hospitals in the state got more than 200,000 doses. Same with monoclonal antibodies. Initially had Lilly, the bamlanivimab, and then the combination product from Regeneron. Federal government bought more than 300,000 doses of each, then were distributed to the states, which we then played a role in getting these to the different hospitals. And then the vaccines. It truly is remarkable that, a year into the pandemic, that vaccines became available. And rightly, it was the breakthrough of the year for Science magazine. Again, the mRNA vaccines, Pfizer and Moderna, followed by the adenovirus vaccine by Johnson & Johnson. So in terms of our initial vaccination strategy, we did pivot, again, data-driven, from what CDC or ACIP had initially recommended, where they recommended vaccinating individuals 70 and older. But looking at how medically vulnerable Florida was, right off the bat, we went to 65 plus. And then also focused on nursing homes and assisted living facilities. So right in the beginning, right when the vaccine first came into Florida, vaccination took place in 2 counties within the state. We also got vaccine to healthcare workers. So we asked all the hospitals in the state for the total number of employees, and we gave them that number of doses plus 15%. The 15% was for healthcare workers in the community. We had hospital, county sites, state sites, FEMA sites, again, focusing on health equity as part of this response. And then if you looked where we were this time last year, we actually led the nation in terms of the older age group, the most vulnerable age group, in terms of vaccination, as shown in this modified shot from the CDC. And where is Florida now? So at least 15 million individuals in Florida out of 22 million have had at least 1 dose of COVID-19 vaccine. And then in terms of monoclonal antibodies, we were faced with the summer surge of Delta. It was apparent that the vast majority of individuals hospitalized had not been vaccinated. Hospitals were really strained, buckling, full capacity. And it was shown that monoclonal antibodies can reduce the risk of hospitalization by 70%. And if we looked at the age groups of different individuals who are getting COVID, and with 70% reduction based upon that, you could actually calculate that for every 2,000 doses, you would save about 50 hospitalizations. The state did a great job in terms of standing up these sites. More than 120,000 individuals received monoclonal antibodies, which easily saved 3,000 hospitalizations. So how do pandemics end? So really 3 major approaches. First, public health measures. With SARS and MERS, what happens with those viruses, they did not have an asymptomatic phase. So if you can identify individuals who are symptomatic, you could contain the spread. Mutation to a less virulent pathogen. This is what's believed to have happened with the 1918 great pandemic. But influenza is different than COVID-19. You have mutations with the hemagglutinin and the neuraminidase parts independently, and population immunity, which is going to happen either through vaccination or for infection. So again, I think we need to continue to be prepared. I hope that we've seen the worst of this, but again, this virus has turned out to be unpredictable from the very beginning. So in terms of the pillars for response, basic epidemiology, identifying populations of vulnerability, adaptation of the healthcare system, how do we achieve population immunity, mitigation measures and their implementation, and then enhancing public health action and communication. So let's talk about basic epidemiology. So, we are all, including CDC, are in a really difficult situation of trying to make decisions before we have all the data and the information that we have. So in terms of looking at some of the different variants which are out there, just some of their different characteristics. So the initial variant had an incubation period of 5 to 7 days, some asymptomatic spread, and thought to be infectious for 10 days. And let's compare that to Omicron. Incubation period up to 3 days, asymptomatic spread, almost 30%, and potentially infectious for up to 10 days. And let's compare that to Delta. So again, Delta, asymptomatic spread, but not thought to be as high. The Alpha variant, or as previous was called UK variant, could be up to 10 to 20%. So with each of these different viruses, we do see some differences in characteristics. So for example, knowing that the incubation period is so short really means that contact tracing is going to be very difficult with Omicron. With a longer incubation period, to be more effective. And where does some of these data come from? One of the initial studies on this actually came from South Africa, where they looked at characteristics of individuals who are being enrolled in vaccine trials, and they compared it to earlier phases, where they found that of people showing up asymptomatic, about a third actually were found to have Omicron without being aware of it. In terms of how long is Omicron contagious for, so this is a study, again, looking at viral load that came out not too long ago, which suggests that after 5 days, up to 30% of individuals could still be contagious. And then after 10 days, 13%. So this is why the CDC recommendation that, after 5 days, you can potentially go back to work, but make sure you wear a mask. And that's because of this potential contagiousness. So in terms of, what are the needs? How do we continue to build on these important data streams that we have? Again, continue coordination of global, federal, state viral detection networks, hospital data. Who is ill? What kinds of trends are we seeing in terms of individuals being hospitalized, and public-facing dashboards? What are the risks? It's especially important for individuals to guide their action, and CDC has lots of information on their website. One of the things that I think that we really need to continue to build upon and augment is wastewater monitoring. So we have individual testing, but also at the population level, wastewater can be so valuable in terms of what's happening in communities. You can look at changes in community viral loads, also detect what new variants are occurring. This is a screenshot from the CDC site showing wastewater tracking surveillance sites within Florida. There are a handful of sites, but expanding these, again, filling in the gaps in the rest of the United States can really provide really important clues in terms of what's happening next. And actually, I think just this morning, I actually heard Dr. Walensky actually talking about the importance of this, which I wholeheartedly endorse. And if you go to the Orange County website about COVID-19, they actually post some of their data for this, and it's great. And I made this last Friday, and where they talked about that there was almost more than a 95% decrease since January 20th, indicating that the Omicron surge was abating. But again, something very important. And why this becomes really important is that we're really moving into a situation where individuals are going to be making their own decisions. And I really like, again, Aaron Carroll's writings. There are a few problems with this way of thinking. The first is that safety is not binary. Things are neither safe nor unsafe. What people really need to understand is how risky or safe activities are, not to be told what's forbidden or permitted. They need to know the amount of risk that comes with various activities so they can compare them. Identifying populations of vulnerability. So again, it became very early on, and these are data from the pre-vaccine time, looking at mortality. So individuals who are 85 years of age and older had an 8,700 times greater risk of dying than individuals between 5 and 17. And again, this goes down progressively. This is a virus that really heaps its fury on the elderly. And as we look at, again, from CDC website, again, tremendous information posted on CDC's COVID tracking site. If you look at new hospitalizations, again, this is broken down by age over time. Even with this latest surge, again, the highest group of individuals were individuals who were older rather than younger. And we also need to understand what are the contributing causes of vulnerability. This is a table from a report did with Ursula Weiss, looking at individuals who died due to COVID-19 and what were the risk factors for underlying conditions: Down syndrome, asthma, diabetes, pulmonary fibrosis, obesity, and dementia. So us as physicians, when we're caring for people with these underlying conditions, make sure that these individuals get protected. And identifying causes of vulnerability, there's an interesting article which came out in Lancet where they compared different countries. And they really said there were two major factors, the age and the body mass index of a population. So this was a commentary written by Charles Lane that was published in the Washington Post and said, when we compare the United States to other countries, it's because we have a relatively older population and in a population that is a higher body mass index than other areas. In terms of vulnerability needs, again, defining those who are most vulnerable to illness and implement protective strategies, nursing homes, congregate settings, strategies for the unvaccinated. Now, in terms of vulnerabilities, the unvaccinated, we're all aware of this. Shown here are data from the end of last week, looking at hospitalizations in individuals as related to their vaccination status. In the orange line are unvaccinated individuals, the dark blue line, individuals vaccinated without a booster. And again, showing the importance of boosters is the light blue line, showing this rate is the less. So again, more than, vaccination really decreases hospitalization risks. But we know that there are individuals who aren't going to get vaccinated or can't get vaccinated. And this is why it's important that we have other alternative strategies for when individuals get sick. In terms of the healthcare system, COVID-19 is not the flu. If you look overall, and also even with the most recent Omicron surge, a report just came out this morning out of Japan showing that the mortality is considerably greater even with Omicron than with influenza. We've all faced staffing challenges, healthcare delivery problems. There's been impact on non-COVID care, hospital burnout. I don't have to tell you this. I mean, you're living this in the trenches. And then we have to ask ourselves, why are we in situations where we have to rely on the National Guard, disaster medical assistance teams? I think we need to have a broader conversation about how are we going to put systems in place to be able to deal with surges. And then strategies to reduce hospitalization. We have many more tools now than we did before. So for example, with monoclonal antibodies, a recent article in the New England Journal showing this is against Omicron, that's Trovimab, will decrease 60 hospitalizations per 1,000 patients given this. And this is similar to what was found with Paxlovid, the antiviral agent, which is now available by prescription. And then test and treat. President Biden mentioned this in his State of the Union speech. I mean, this is something which is really important. Tests are available, and it's interesting if the tests that have been produced, only half have been requested. We need to get more of those out, and I love the notion that if you test positive, that you'll be able to, or get tested at a pharmacy, that you'll be able to get this antiviral agent, because the sooner individuals are treated, the better. Decompress emergency rooms and urgent care centers. I heard the stories of people going to hospitals to get tested because of EMTALA regulations. Individuals, if they want to get tested there. So we have the non-hospital sites, decompress emergency rooms. And I was on a call earlier this week where individuals from Maryland were discussing the fact that they actually set up testing centers in front of hospitals so individuals could get tested, so individuals who need emergency care would be able to go in there. And then again, continue to emphasize to the public what to do if you're symptomatic. And then the role of primary care. Primary care plays such an important role in healthcare, and really continue to support primary care as COVID care really transitions out of the hospital setting. And then in terms of population immunity, one of the questions that we don't know the answer to is how many are enough before we end up getting enough immune protection for society. Shown here are data from earlier this week, again on CDC website. These are based upon studies that they're doing for individuals all across the country, where they look at seropositivity rates, and they can, by looking at nucleocapsid, as a target, you know the antigen response is not due to the vaccine. And overall, looks like about 43% of individuals in the United States have had COVID-19, or 140 million individuals. And it's also interesting if you look at the age groups, where the age group that has the highest proportion are individuals 0 to 17 years of age, where it's almost 60%, and this goes down. In terms of vaccination, about 65% of individuals in the United States are fully vaccinated, with 43% having a booster dose. So what this means is that we still have more than 1 in 3 Americans still who are not fully vaccinated. And with booster dose, as I showed you the data, it does a really additional job in terms of protection, and we need to continue to emphasize that. In terms of the risks of different approaches, vaccination immunity versus post-infectious immunity. So in terms of vaccination immunity, there are nearly 547 million doses of vaccine given. On the Vaccine Adverse Event Reporting System website, they talk about there being about 12,000 deaths associated with vaccination, but those actually directly caused by vaccines are really very few. Versus post-infectious immunity, we've had nearly 1 million deaths of COVID vaccines related to 80 million cases. So a case fatality rate that's almost 1.2%. So the data are pretty clear. If you really want to protect yourself, you should get vaccinated rather than get infected. And then in terms of infection prevention, again, this slide shows the value of having booster doses related to infection, but even more dramatic, the effect on decreasing death. In terms of misinformation, this is something which is really important, really is limiting our activities. This is an article that came out just this past Friday. In terms of misinformation, this is based on a national survey, almost 20,000 individuals. So here we are. 10% of the population believes it causes infertility. 30% aren't sure if they do or don't. In terms of microchips, about 6% of the population still think these vaccines can track people. 20% not sure with this. In terms of mitigation measures, so again, mitigation doesn't mean eradication, it means reduction, where the goal is to reduce the rate of spread and protect individuals. And 3 major pillars: ventilation, identify and isolate, and masking. So, it became pretty clear early on that the outdoor environment was much less risky than closed, crowded spaces. So this is why it's important, the issue related to ventilation. And CDC has some nice guidelines in there about ventilation, certain measures that individuals can follow. One of the things that I became aware of early on is the importance of looking at monitored CO2 levels. And this is actually a screenshot from the UK. And actually in my office, I had one of these CO2 monitors. And when I had calls with the Chamber of Commerce, when I would speak with them, we would talk about this, because people say, how do we know that we have enough ventilation? So greater than 1,500 parts per million, inadequate, and then less than 800, good for ventilation. And in the UK, they actually pushed out 300,000 of these devices to all the schools in the UK for their use, to get an idea in terms of what's going on. And here's a screenshot of one of these devices that you can now get for under $20. Let's talk about masks and their origin. Well, this actually goes back to the pandemic of 1918. And if you read John Barry's wonderful book, The Great Influenza, he talked about this. So there was a major in the Army named Capps who noticed that in the barracks that soldiers were getting infected. And at the time that these masks had been used in the operating room. So he did a study. So far as we can learn, however, the use of face masks for patients has never been practiced. In the hospital where each patient is confined to a separate room, there is no reason for masking the patients. But in hospital wards, where even with cubicles, patients must mingle, face masks theoretically may give grounds of protection. And he did studies showing that it actually was effective there. In terms of face masks, 2 potential modes of action: stopping the spread and protecting individuals. In terms of stopping the spread, this is a recent report where they compared no masking versus surgical masks versus N95s compared to single layer paper towel or cloth. And what they find is that surgical masks or N95 are much more effective in terms of stopping the spread of aerosol particles. And CDC provided some updated guidance about this quite recently, comparing nothing, cloth masks, surgical masks, and N95 masks. Now, one thing to emphasize is, for N95 masks, though, those of us as physicians, when we have patients, particularly those who are medically vulnerable, who want to protect themselves, that the N95 masks are really properly fit tested in their guidelines for this. And CDC, as we're all aware, last Friday issued new guidelines for masking recommendations based upon community level. And then isolation and testing. Again, isolating affected individuals, it's a basic public health measures. If you're sick, you don't go out in public, and this is not new with COVID. So we can have identification based on symptoms or on testing. And this is a screenshot of my test kits, which came to my house this past Thursday night. So if we have questions, we can all test ourselves. Bountiful. In terms of schools, again, symptom screening. When schools went back in session, this is something that we talked about, but now there's also testing available. I know there's some talk about test to stay programs for exposed students. And here, this really is dependent upon the performance of these rapid test kits. It's very clear that they are very specific. However, in some situations, you may be missing 40% of cases, and these are individuals with relatively lower viral loads. So when we use this, sometimes it can give a false sense of security, but other times not. And the not is when they're used serially, which is why it's important that these are available. And lastly, how do we really enhance public health and communication? How do we rebuild public health? There's been tremendous state health officer turnover. Recent calls in with ASTRO, I think they mentioned that half the state health officers have turned over during the pandemic. We've seen leadership questioned at federal levels. There have been attempts to abolish departments of health and challenges to longstanding public health practices. Shown here is a screenshot from a New York Times article talking about the states that have actually had new laws to limit public health. There have been efforts to abolish departments of health, like in Tennessee, for example. And Michelle Williams wrote this article about the same time last year, talking about different strategies, recognizing that this is a problem. So things that we need to work on. What can all of us do? We really to reinforce the notion that we are a trusted and credible source of information. We need to continue to make sure that we have clear and understandable messaging and consistent messaging as well. And again, getting back to a recent piece by Aaron Carroll, to fight COVID, we need to think less like doctors, which means that thinking like doctor means you focus on a single individual rather than society. So if we're trying to prevent COVID surges and end the pandemic, we need to center the population in our thinking. Health authorities need to get the tools like rapid tests and better masks to as many people as possible, especially those likely to spread the disease, even if they're low risk themselves. People need to be persuaded or incentivized to vaccinate to protect others. And lastly, of the many books I read during the pandemic, this passage from Albert Camus' The Plague really sticks with me. It can only be the record of what had to be done and what assuredly would have to be done again in the never-ending fight against terror and its relentless onslaughts, despite the personal affection by all who, while unable to be saints, but refusing to bow down to the pestilence, strive their utmost to be healers. And all of you on this call and your colleagues are healers. And for this, we thank you. Thank you so much for your attention.
What a wonderful presentation. I had a question, Dr. Rivkees. There's some discussion about parallel evolution of COVID-19 in the animal kingdom. So a spillover event from animals to humans seems to become a reverse spillover or spillback into the animal kingdom. I think that vastly complicates our calculus about who's going to get what and how to predict the future. Would you share your thoughts on that?
You know, if you look at the origins of COVID, it's pretty clear that it starts with bats and goes to an intermediate host. Bats account number-wise 20% of mammals on this earth. And there's certain things about their immune response, which means if they get these unusual viruses, that they don't mount a response that will kill the host. And then also, stories about COVID going into hamsters, mice, deer. You know, with a virus as complex as this is, it is possible that will lead to a different variant events at all. So I guess, carrying your thought a little bit further, we've talked about monitoring in humans. We probably, and I know that there are studies going on looking for other zoonotic infections as well as part of this.
Thank you.
I had a
Go on.
question. First of all, thank you, Dr. Rivkees, for your presentation, being so comprehensive. But one of the things I didn't hear you talk about was early treatment. I mean, you talked about the success with the monoclonal antibodies, but what about other early treatment, beginning with even simple things like taking vitamin D, which is not a cure-all, but certainly it boosts the immune system, has protection, offers some protection against viral infection, particularly since a large percentage of the U.S. population is deficient in vitamin D, and also a whole slew of repurposed drugs. And it's not just ivermectin, which the FDA unfairly mischaracterized as a horse dewormer, one of it, but there's a number of studies published, everything from inhaled budesonide to fluvoxamine and so forth.
Yeah, important point. You know, first, I'm an endocrinologist and know the vitamin D literature quite well. And you're absolutely right. There are individuals who are vitamin D deficient, and individuals who are vitamin D deficient really should have vitamin D replenishment. But in terms of, it's like antibiotics. I mean, there also is evidence that individuals who aren't nutritionally replete can be susceptible to bacterial infections, and we use antibiotics rather than nutritional supplements. And similar situation here, where we have drugs that have been shown to have true rapid antiviral properties. So again, this is a situation where, it's great that the FDA has a number of studies which are going on looking at other medications which are out there for potential therapeutic effects against COVID-19.
If no one else has a question, I'll ask another one. Another controversial aspect has been the mass vaccination campaign. As you point out, the vaccines have been effective in reducing hospitalizations and deaths and that, but you also point out that the various risk factors, not all the population has the same risk. And you mentioned about the VAERS data, that less than 100 deaths associated with the vaccine. But one of the criticisms of that has been there hasn't really been an independent body to investigate that. And it's not just the VAERS in the United States showing a very high rate of death. For instance, the number of deaths and the adverse events associated with the COVID vaccine exceeds that of all other vaccines in the whole 30-year history of VAERS. But we're also seeing a very high number in the yellow card system, and for instance, with us in the UK, and for instance, with other countries that are seeing that as well. but why hasn't there been an independent body to thoroughly investigate that? Because you could argue there's some conflict of interest with the U.S. government doing it, since the U.S. government is a co-patent holder, for instance, on the Moderna vaccine.
Yeah, I can't comment on independent bodies or groups would do this. I'm not aware of that, but just having been involved with NIH, CDC, FDA, and what the process is for drug approval and things like that, it really is a data-driven approach.
Are there any other questions?
I'm sorry, I was on mute. What a wonderful presentation. Thank you very much, Dr. Rivkees. We look forward to having you back soon, and we love your quote by the plague. Have a good day.
Thank you so much.
Thank you.
Thank you.
May I help you?
Yes. Did you hear back from your friend? I guess you were running it by on that one day that you wanted to have off. I gave you 4 different dates and then you texted someone.
Oh, yeah. He said